All right. We are back. uh, all right. Aloha, guys. Thank you so much, people.
Hi. Wow.
Ah,
Sorry about all that.
no, it wasn't you. It wasn't you. It was just the glitch. The glitch.
The
So
glitch.
thank you so much. I'm just setting up everything up here again, real quick. We're about 15 minutes late. I told everybody we're gonna make it up for them with this
That's fine
amazing.
with me. I'm really sorry about all this.
It's not you, my
Oh
friend.
no.
I take full responsibility. So let me just get my stuff all set up here, which I usually do ahead of
Hi, Charlie.
time.
How are you doing, Doc?
By the
How
way,
was your
that's
day
Charlie
today?
up there. That's Charlie. Look, we picked up most everybody's back. So we're gonna pretend like that whole first 15 minutes didn't happen. And we're
Okay.
gonna start over fresh. Thank you, everybody. Welcome to Facebook Live with Mel and Charlie. Tonight we have an amazing guest. We spoke so well and so highly of you on the first 15 minutes. So just remember what I said about Dr. DeWolfe Miller, and we'll let him introduce himself in a little bit. But as I was saying in the early segment, many of you may recognize Dr. DeWolfe Miller from the what I call it was really the world-changing press conference that was held with Tulsi Gabbard, with
Oh,
Scott Missy,
yeah. Wow.
and our hero, the hero, uh, Dr. Jennifer,
Jennifer
who
Smith,
Jennifer Smith, the whistleblower. She
the
became known as the
whistleblower.
whistleblower,
Right.
and he came out that day. Dr. DeWolf was there. He spoke about some numbers. He had his charts. Um, and you become real famous since then, and actually before then. But so many of you might recognize Dr. Miller as that person. It is. I had a couple of comments after I put up the promo piece. We got a couple of comments. Isn't this the guy that was with the whistleblower? Yeah, this is the guy.
That's me.
So again, I'm Mel. That's Charlie. Doc, if you want to
Yeah.
take a few moments to just introduce
Yes.
yourself and share with our viewers what exactly you do.
Thank you. Well, first, thank you for inviting me. And yesterday, I was with you for that whole meeting you had yesterday with the mayor from Kauai. And that was, he is just really impressive guy. I mean, that was just an amazing performance. So I'm going to do the best I can here, but that was very polished. And he's, like I said, it was just really terrific. So my name is Dr. DeWolfe Miller. I, I've been doing epidemiology for a good part of my life. I started as a assistant professor at the University of Michigan in the Department of Epidemiology, studying under a guy that was very famous in respiratory disease infections, and which included influenza and coronaviruses, which we didn't think much of at the time. And I also had worked previous to that. I'd spent already, before I joined the faculty, 4 years in Egypt working on parasitic diseases up and down the villages along the Nile, which had really started my career. That really kicked my career off. And so I continued to work at Michigan and work in other places around the world. I had previously worked in the earlier 70s before that in Iran, in Shiraz, where I actually decided to become an epidemiologist. And so after Michigan, I joined the American College of Epidemiology. That's our accrediting organization for epidemiology, and became a fellow in the American College of Epidemiology. That was after I moved here, and I moved here like in the late 80s, and to head up several programs in public health. And so originally I was a professor of public health and epidemiology, and ultimately became the chair of the doctoral program in epidemiology for about 6 years or something like that. But all along, I knew that there was a department of tropical medicine in the medical school. And since really tropical medicine had been one of my great loves, which I continued to do, like almost all the 1990s, I was more in Egypt than I was here. working on these diseases. And hang on. And so that whole experience shaped my infectious disease epidemiology, because we discovered other epidemics, which we continue to work on this day. In fact, I was most of last year, I was again in Egypt working on the biggest epidemic of hepatitis C in the world in Egypt, which we discovered. I discovered it with my Egyptian colleagues, a very famous woman named Dr. Momina Camel. And last year we completed a screening of 67,000 people in the South, in Luxor, around those areas of villages and communities, in which we screened people for hepatitis C for free. Okay, and then if they were positive, we treated them for free with the new drugs, the direct acting antivirals. We must have cured maybe 7,000 people, because 15% of them were positive. There's not any place in the world like this. And we also discovered a small epidemic of hepatitis B along the way. And we published that in November. And if you want to know about me, just put F. DeWolfe Miller in the Google search, and you'll get a couple of links. And the second one is my CV. And the first blue link is that paper, and you can read all about that. And so then I came back here and finished my career out. I'm an emeritus professor now as of January. And we have an epidemic. In fact, one of the most remarkable things I have to tell you about my career is that last year and all the years before, when someone had asked me what I would do, I would tell them I'm an epidemiologist, which was usually in America a non-starter. Maybe they would step back, yeah, you know, or maybe they would even say, oh, he's a skin doctor. Yeah, okay. And so just recently, I was talking to this guy. He figured I didn't want to ask him. I said, I'm an epidemiologist. You know, I study epidemics. And this was here like a month ago, and it still didn't connect. It's just no connection. And so I've had a really great career. This is just a sketch of some of the things I've done, and I had did what I got lucky, because I had decided in Shiraz that that's what I wanted to do. I'd already trained in virology and immunology, had a really good, strong background in that. And I really wanted to be outside and go to crazy places, maybe help a few people.
Well, I can tell you that before I reached out to you, I Googled your name and I did read your CV, and then it scared me. Like, I don't know if I want to bring this guy on. He's like, he's probably not going to respond. Probably not going to,
It's a pleasure to be here, Mel. Come on. We talked earlier about this. Come on. Charlie, he's putting me on.
No, I'm not. I tell you right now, I'm not. Charlie will attest to this, because I share with Charlie everything when we talk about a guest. But the bottom line is, the point I'm trying to get across is Dr. Miller is a scientist. He's an expert. He's an expert in the field. He's world renowned, and we got him here at our
disposal.
I was going to say disposal, but that doesn't sound cool. But we have him here tonight to pick his brain. Like I told the viewers before the glitch occurred, was that, you know, we're not going to get into policy and politics, but we want to get into the science of this thing. We want to get into.
I would love to do that.
Yeah, and maybe epidemiologists. Not too many of you running around.
No way. This is what I wanted to say. First, I want you and Charlie to interrupt me at any point. But I discovered that there is a plague going on. I mean, as of a year ago, I couldn't find an epidemiologist. Today, there's epidemiologists everywhere. I mean, everybody's an epidemiologist. It's amazing. It's really amazing. I said, you're an epidemiologist? No, you know, they're just everywhere. It's unbelievable.
So, you know, just to understand what epidemiologists do, I don't want to waste any time with a lot of that stuff. I just really want to, you know, our show has been dedicated to COVID-19, and there's been a lot of discussions. We've had numerous doctors and experts from all over the world come on the show, and we're excited to have you here. We want to really, in layman's term, that's the only thing, bringing somebody like yourself on our show, and then and I do this for the benefit of myself. You know, I'm not a doctor, so I gotta, you know, you gotta kind of dummy it down for me, so we can kind of relate to what is actually going on with COVID-19, the infectious rates. I know I sent you over a chart that our good friend Brian Ingalls sent posted on Facebook. I reposted it. I'm not sure if you had a chance to take a look at that about the infectious rate and so forth. But maybe just talk to us about COVID and based on your studies and your information, what the heck is going on here with this
Okay,
virus?
so I actually had prepared some of that stuff and I had to reboot a minute ago. So just give me a second to pull this up. I'll give you some background stuff that we've been working on. So I work with a group of people. Dr. Sumner LaCroix, who just called me, who's a professor of economics. Tim Brown, who's a senior fellow at the East-West Center. He's a infectious disease epidemiologist for United Nations AIDS, AID. I've known these two guys, they're just close friends. And then John Dorkin, an infectious disease doctor over in Hilo. I've known, he's really outstanding. Okay. So there, and some other guys that we just kind of like make a group. Okay, so one of the things that we were talking about just recently is the case fatality rate here in Hawaii due to COVID. So if you said, okay, Hawaiians, let's say we have total cases of 1,068 like last week of Hawaiians, and the number of people that died that were Hawaiian. And so then you divide those two and you get a rate, okay? And so I've done that for all the different races, Pacific Islanders, Filipinos. So guess who is the highest and the lowest? And the difference is huge. The difference is between 1 and 5. So you have people that are less than 1 and some of the groups that have a case fatality rate of 5.
Pacific Islanders.
Not particularly. They're right in the middle with everybody else, if not a little bit low. They are 1.6.
Asians.
They had 1,000. Sorry, Charlie?
Asians.
Well, you're right, but there's a bunch of different kinds of Asians around here, buddy.
Yep.
Yeah, you want to pick one?
I'll go with Japanese.
You're right on the money. It's 5.5. They're the top. Okay. Now, don't tell it. I think you know why, Charlie. So don't steal my thunder here right away. Okay.
No.
So following that, the lowest is. Come on, guys. You're right. 0.6, 0.66. Can you see my screen over here? Are you peeking? So here's how it goes. So the Filipinos are 1.8. The other Asians are 3.5. The Halis are 1.3. The Chinese are 5.2, and the Hawaiians are 0.66, just about 1. And the Japanese are 5.5. Now, this obviously can be adjusted if we had the age of these people, but this was data that I gleaned in little tiny pieces, trailing after the people at the Department of Health, trying to, as a beggar, looking for some crumbs to get. Okay. Mm-hmm. And so I can't do that. I could do that easily as an epidemiologist, is to see what the impact of age is here. Like, for example, if you're going to compare where I was in Ann Arbor, Michigan, the mortality rate is very small compared to Miami, which is very high. You wouldn't want to go to Miami. It turns out if you look at it by age, it's the same. Okay. So that's called confounding in epidemiology. So I have a chart here that shows the rate of COVID in different races. Okay. And so what you usually see are the number of cases.
Doc, real quick, Doc, you can share if you're on the computer, if your chart is on your computer, you can share your screen if you want.
I don't know how to do it.
Okay, that's all right. Go ahead.
I'm sorry, I'm such a klutz on this. And besides, this is a particularly sensitive piece of information. Okay. I'll just relate it to you. So first, I want to make sure you understand the distinction between some cases, and out of a particular, say, week of cases, you have, say, 30% are Pacific Islanders, another high percentage groups of cases will be Filipinos, and so until it totals up to 100%. Okay, but that really doesn't tell you what the rates are, because the populations of each one of these groups is very different. So if you had a very high number of cases and a very low number of population, like in the Pacific Islanders, you've got a lot of rate going on. In fact, the rate in the Pacific Islanders is much higher than everybody else's. Okay, I mean, it's just no comparison. Now, this has been published with Tim Brown and David DeWolfe, another friend of mine, in a East-West Center Wire publication, okay, maybe a month ago. And when we published that, we were already in contact with community leaders from the Micronesian communities, because this is where most of the Pacific Islanders are coming from, with Micronesia. Ironically, and I've worked all through Micronesia, from Majuro to Palau, okay? I know those islands pretty well. So ironically, the cases in those islands in Micronesia are either 0 or 1. All the cases in Micronesia are on Oahu. They closed off their borders as soon as this thing started. They just closed off travel. Okay, and so Samoa, another Pacific Island group, which is much smaller here, have no cases. All because they just shut their borders off. All right, but the Pacific Islanders here, once I started contacting them, they jumped into action. They needed the attention. And so I was getting them attention on the local media. I was getting attention through their other leaders. I really just put people together. They did it. They've got some really great people. I would like to mention Jocelyn Howard, Josie Howard. She's just fabulous, you know, and she's my current, because they really have knocked it down a lot in a very short period. This all started back in August, okay? But if you looked at the East-West Center Wire report, you see the really dramatic trend between the Pacific Islanders and everybody else. And everybody else, ever since back in July, have just been kind of puttering along with the Howleys slightly higher than the Hawaiians until just the last couple of weeks. And then the Hawaiians went above the whites. But the differences here are just like this on the graph, okay? Whereas on the Pacific Islanders, it's huge. It's way up here. If my finger helps you visualize that graph any, okay? So these are things that are important that need to be brought into bear in terms of the transmission of the virus from person to person. So how does that happen? This is really the key, is transmission of this virus from one person to the, this is the key to epidemiology, because the key to infectious disease epidemiology is to reduce or prevent altogether that transmission. We've done that for smallpox. We stopped that transmission of smallpox 1979 with a vaccine, okay? So we're looking at, we're waiting for a vaccine for COVID. And I think we will have one pretty soon. But the thing that I've been hearing in the background is like, well, I don't want to take it. And so I was like a month ago, I was on one of the TV stations and I got the guy to give me a plug to ask me about flu. And I said, hey, by the way, everybody, get your flu shots. For heaven's sakes, you do have a vaccine for this. And you should get your flu shot, because if you get both of these viruses at the same time, you're going to be in really deep, well, whatever you call it after that.
Kimchi. Yep.
Yeah, right. Okay. And so this is the time, because we've noticed for years that if you immunized all the kids before they started school for flu, you wouldn't even have to immunize the old folks. That's the power of immunization. Okay, the power of immunization is that, oh, well, great, I won't get the flu. But better yet, I won't give the flu to anybody. The kid that died from flu down the street wasn't on my head. Okay, so this is the lecture that until this last semester, every Wednesday at noon in the auditorium of the medical school, I had a seminar, tropical medicine seminar. And every fall, that the place would fill up with students and faculty and staff. And I'd start in on them. Get your flu shot. I know some of you out there lying and didn't got your flu shot, this whining around. And I said, I really don't care if you get sick. What I care about is that you gave it to somebody else, you jerk. Okay, and this is how, so I'm real popular there at the faculty. They're happy I retired. But I'm an emeritus professor. Okay, this is a very important distinction. Not that it's an honor, but it keeps me with institutional affiliation. I still have my office. I still have my email address. I still have access to the Library of Medicine, National Institutes of Health. Oh, an old friend of mine's coming, okay? Tomorrow morning. Tony Fauci is going to be online. Did you all hear about this?
Yep.
Mhm.
Okay, so there was a guy working with me here for years named Dr. David Morins in my faculty. We were really close. He was a tropical medicine guy, he was an infectious disease guy, and 10 years ago or so, he said, I just can't take anymore. I gotta get out of here. Okay. He had an offer at CDC, he'd been in the public health service, he's a brilliant guy. He says, I could go and work for Tony. So what are you talking about? You go work. Well, go work for Tony, for heaven's sakes. I mean, Tony's been famous forever. And so David is his senior science advisor. He just sent me an email today. Okay. I stay in touch with David. We're old friends. I kind of know what peanuts that Tony's eating on any particular day, and Tony's a great guy. I mean, just personally a great guy. And so I think that for him to be here is a treat. Okay. It's nice, however you want to take it. And I know that people are thinking, oh, this is all political, and you can take it however you want to, but I would prefer to keep the politics out of it and stick with keeping the transmission of the virus down. So how many of our audience know the difference between a virus and an elephant? COVID virus in particular. They have some things in common.
I'm reading the comments. Doesn't seem anybody knows the difference, sir.
Do you know what's the same? So the virus and the elephant use the same nucleotide base codes for making proteins from 21 amino acids. All of life does.
Okay.
So this is the secret of life, is those nucleic acids that make up DNA. But then the elephant is different from the virus because the elephant is a DNA organism, a rather large one, no doubt. There's something else that they have in common. Very large one, no doubt. But this virus, and only viruses are like this, viruses come in two types, DNA and RNA. So when you're talking about this virus and you're talking about PCR, the polymerase chain reaction, you're not amplifying in the first stage DNA, you're amplifying RNA. Now, RNA is a knockoff of DNA that viruses figured out how to use to trick people up, because viruses only do one thing. They infect other organisms, okay? Here's a virus that wiped out our papaya. There's a guy named Dennis Gonzalez, Dr. Dennis Gonzalez, that grew up in Hilo and got his PhD and went off to Cornell or Columbia, I forgot which one, and gave us a papaya back that was resistant to that virus. Thank you, Dennis. He's a really good guy. He could do that. This is really amazing technology. And so the thing that a virus and an elephant share is that neither one of them can go through a mask. You know, the one you put on your face? Really hard for an elephant to go through this. It's also really hard for a virus to go through it. Now, somebody described this phenomena as a mosquito going through a chain link fence. It's a bad analogy. It's a false analogy. So when we breathe in and out, and if we were infected but not sick yet, we would be breathing out virus, right? But they're not individual particles, although viruses are the smallest things that exist. I mean, they are so small, they even infect bacteria. This is how we learned about them, about how they infected bacteria. This is our first evidence of virology, was phage virus. This is what they're called, the ones that infect bacteria. They're fascinating. It's fascinating stuff. That said, they actually do not come out of your mouth as individual virus particles. They come out of your mouth with moisture. If you've ever been in a cold climate, you guys probably don't ever know what a cold climate is. You can see your breath. That's moisture. Okay? And so they come out wet in clumps because they're so small, they'll electrostatically clump together in globs of what, let's see if I can find a mucus. It's snot, is what it is. Okay. And so,
Gala, 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 gala.
yeah, okay. And so that stuff doesn't pass very easily through any of the masks that we, I mean, a washcloth would stop it. Okay. And that will disrupt transmission. Okay. Now, what kind of transmission is that disrupting? Direct transmission or indirect transmission?
Say indirect.
I would say direct. I mean, it's direct.
Hey, we got 1 for 1. This is good.
That's why we're a team.
Defend your
That's why we're-
positions, gentlemen.
Yep, I say indirect because it has come off the moisture.
And Mel, you said direct.
Mhm.
Okay, so if I'm this is actually a little bit complicated. So direct transmission is me, I'm infected, I'm breathing, I don't know it, and there's somebody standing directly in front of me. As I breathe out, they breathe in. That's airborne direct transmission. So if I put a mask on, it interrupts that because it didn't get past my mask. If he puts his mask on, it interrupts that because it doesn't get past his mask. And if we both have our mask on, we have double protection that we're not going to transmit this virus. It's really good. It really works. It's really low technology. So now that I have told you what direct transmission is, what's indirect transmission? This is a problem, indirect transmission.
It's when the whatever the is being
Now,
expelled.
don't talk about picking your nose.
No, it lands on the surface, and indirectly somebody comes in contact, right?
That's exactly correct.
There you go. Thank you.
So you have something that
answer.
protects you. You have something that protects you right now from some of the indirect transmission. Those are those eyeglasses.
Exactly.
So people that wear contacts, I'm a little bit worried about. And so people that get infected and they've been doing everything right, they're wondering about it. And it's because of this indirect transmission of occult ocular transmission to the epithelial cells, which have the receptors for this virus all over the place. That sounds sophisticated?
You know what? Sounds freaking impressive.
I
practiced it before I said it this afternoon.
You know, Doc, I do want to share with you. I learned this a long time in medical class in grade school when I was in the 3rd grade. Is when somebody's talking way over your head. This is what you do most of the time, and you'll see this only in Hawaiians. We'll do this the whole time. Because we're trying to grasp what you said. So what
Sounds
you're
like
saying is, so what you're trying to say is that if it gets into your eyes, there's something back there. Well, I mean, are you saying that
we'll pick up the virus?
Well,
Something back there will pick up the virus, but it was your fingers that got it there.
Right.
Okay, so this is why the kids over in Ilani's school near me are going to school with a mask and a shield. This is why you get on a plane. It's better if you have a shield because you're going to wake up after you fell asleep somewhere because there's no close. I mean, right now, after all the travel I do, my brother-in-law lives over in Hilo, and that's about as far as I can fly. It's the only place I can fly without jet lag, and I'm fed up with a lifetime of getting on airplanes. And so, but I would if I'm even going to Hilo, I'm going to put on a mask and a shield or safety glasses. Scott Mescovich took off to the mainland a month or so ago, and I was ripping into him about being safe on the airplane and not getting catching COVID himself. He's the guy who set up all this street side testing, in spite of the fact that everybody said there's no tests around, we don't have any PPE, and he just did it all. You know, this was a pretty cool guy. And so early on, I went over and gave him a copy of my paper, 67,000 people that I had already tested along the Nile River. And he had some time, I was giving him some time to catch up. Okay, he understood that. He was sitting there in Kakako Park with the Pacific Island behind him. I thought that was pretty nice. Okay, we were sitting there talking, and we hit it off right away. I mean, the guy just seized the day. You know, he did what everybody said couldn't be done and provided a valuable thing. And so we collaborate a lot. He's also a person that so one of the things I want to hope that will happen while I'm rambling on here is that people ask questions about transmission, about how we can interrupt transmission, even in the face of whatever else might be happening, and how good can that be, and what you can do to participate.
Well, let me kick it off because I know right now the topic of the day is the travel, and everybody's concerned about travel and about virus coming in from the mainland or from anywhere. Trans-Pacific could be Asia. It doesn't matter. Um, the the safety of flying, the risk of transmission of the virus in an aircraft. We've heard from airline industry officials that it's the safest place to be. I heard it out of their own mouths that there's many other the air in an aircraft. It's safer to be than many other places. And the what's the transmission range of people? Let's say they take off their mask, whatever. How safe is it to fly in an aircraft for 6.5, 7, 10 hours coming to Hawaii?
This depends on you. The aircraft people are doing their part. If you've got some jerk sitting beside you who's got an open water bottle as an excuse to keep their mask off, you got a problem. You hear me? You understand what I said? Because you got your mask on, you got your shield on, and you're good. You don't even have to take it off to go to the bathroom. Right?
Mm-hmm. I saw the news article about going into the restroom. It's possibly a very dangerous place to go because of the person before you. Someone could have sneezed or coughed or left some droplets in that.
That's right, and have indirect transmission. Right, but you've got a mask on and you got a shield on. And guess what you did before you left the bathroom?
Disinfect.
You washed your hands.
Yep.
Right. Yeah. I mean, this stuff is like infantile almost. I mean, I've tackled really complicated transmissions of epidemics in different places in the world that were just like this hepatitis C epidemic was really tough. I mean, this is just, we can do this. I mean, look, on Thursday, I have to meet a group of students on campus. Well, actually, I'll meet them on the computer on campus who are in the Department of Philosophy that are going to review the notes of the Black Plague in Iberian Spain and Northern Africa by Islamic scholars in the 13th century, the 1300s. Okay, and so I had to read some of this stuff, and I'm thinking, Jesus, we're more stupid than these guys in the 1300s. I mean, the scholars were sort of sorting it out, and they didn't have the real mechanism, but they knew that putting space out, they had critical thinking even then, and we're not even using that ourselves to protect ourselves. There's not anything that the things that we want to do, which is be together in large groups, is too bad. Okay, that's not a good idea. All right, whatever it is. About the only time I want to be in a large group is on an airplane. Okay, and I can't even be on an airplane now. And that's a good thing, basically. And so the other one is, if they get here, I'm worried more about us giving them the COVID virus than them giving us. They're going to have a mask on, aren't they? We got knuckleheads over here, COVID knuckleheads over here that don't wear masks. I talked to Mike over in Maui a lot about this. He said he's the one that gave me the term knucklehead anyway. Okay. Right. So he gave me a new epidemiologic term called COVID knucklehead. And I don't know what to do about these people. I've seen really intelligent people walking around in crowds of groups and thinking, I just don't get it. I mean, other countries have succeeded without even lockdowns, just because they get cooperation among their people. The Pacific Islanders to do better.
Well,
the leak. I'm sorry, Charlie. Just before I forget it, the other leak is if they don't take the test, they're going to be quarantined, right? Mm-hmm. So, where's Angela Keene when we need her?
She's on here tonight. She's on here tonight.
Well, she's priceless. She's Scott's partner in crime. Yeah. Okay, because the state isn't doing it. All right, and so you got to get her out there, and you got to get her. You got to give her every resource she wants. Okay, I mean, you got to double up on that.
We agree.
And so that's something that takes more than just the individual participation. It's this silly quarantine stuff, and it absolutely has to be locked down. Okay, and she's there to help us, but we got to help her. Right?
Well, last night we posed a question to the mayor regarding mandatory masks, and it goes to what you're saying. Some of these people, what's wrong with them? They don't want to wear a mask. But then, just short of, forcing it upon them, it's just,
He was so eloquent about that.
Yeah.
He was really eloquent answer, and I listened to it very, very carefully, and he didn't answer it.
Yeah.
He was really beautiful. I couldn't do that. I just couldn't get away with it like that. It was just really smooth. And so, yeah, well, you can, because you can talk to another human being and tell them. And we got to empower ourselves to do that. Put the guy put him back on his feet. Put him back on his heels. Put him back on his heels, not on his feet. Put this knucklehead back on his heels. Gang up on him if you have to. But I mean, we need to empower just ordinary people to tell the other person that you need to do this. We need almost complete mandatory masking. The graphs that I was looking at today from Tony's office, okay, was a projection of COVID here that's going to go up in January to way above what we have now, unless we have that masking.
Okay, so let me ask you the $1 million question, okay? And this is not a political.
How much you want to split it, or do you want to give some to Mel?
I'm going to give it all to you, because this is coming from someone who deals with this stuff year round. But because we are opening, I'm just trying to understand it, that, and you said it, that you're worried about us giving it to them. Right now,
this was almost, Charlie, this was almost a little bit of a snide thing to say, but I mean, if they're wearing their mask and we're not, and we've got more infection than anybody on that plane does in a prevalent situation, that's what we would be doing. Okay, I mean, I could see that. It's not completely beyond the responsibility.
But what about if they are coming from those places that we know are hotspots right now, coming to Hawaii? Because I got to take a look at some numbers that the lieutenant governor published, which kind of addressed the uptick in market sales for travelers coming to Hawaii basically from October all the way to February. They did a small cutaway, and it basically showed the numbers were higher for Kauai and Maui and lower for Oahu and the Big Island. And the only thing I could attribute to that is because the infectious rates in those two counties, Oahu and the Big Island, is much greater than Maui and Kauai. So based on that, I'm just thinking, well, if I had my druthers, I'll travel to someplace that's safe. But now, if I'm coming from someplace that's a hot zone, I'm just wondering, is it possible? I mean, it's possible, but what's the likelihood of a group of it coming towards us? I guess that's the question.
In June, what comes before June?
May.
May, thank you. In May, I went to Sumner and I went to Tim and I said, I know how to do this, and we know how to do this, and we're going to write it up, and we're going to publish it under UHERO, John A. Burns School of Medicine in the East-West Center, and we published it. It became a document that we get emails from all over the country on. Okay, and it sets the stage for how to do this. Okay. And it has to be modified accordingly because times have changed. We have new tests, but the principles of how to do that are there. Okay. It's test first or you get quarantined later, in short. But we made it a sophisticated epidemiological statement on paper. Okay. The rest of everything else is just people talking. All right. If they want to do something, then put it in writing and get it peer reviewed by somebody. We have it peer reviewed by those institutions, and then go for it. All right. So the idea that they come from a hotspot is not relevant. It's only relevant that they got tested before they get on the plane. Okay. And even more importantly, so I've been teaching testing for 30 years to doctoral students in epidemiology. It is the tool we use. I know a little bit about it. Okay. So you do what the blood bank does. They have to test it right every time, right?
Mm-hmm.
They can't screw around. They'll kill somebody. So they get picky. It's called pre-screening. Okay. You pre-screen the people. You say, okay, you're going to be a tourist. You got a return ticket. We have a whole list of questions here that you need to answer. And since we don't have mandatory masking for the plane or in Hawaii, we'd really like to know that you aren't, you actually want to invest in a vacation here and have it be successful and not get sick while you're here. So that traveler is pretty motivated to do it right. Okay, to be honest and to be wearing a mask and to get tested. Besides, those people, if you screen those people, that test is going to work a hell of a lot better. It's called Bayesian probability. And if you want to make it better, you do two, and that's called multiplicative probability. I can't wait to tell you about these probabilities. I was wondering when you were going to ask. Jesus.
Hey, Doc, real quick, because this question popped up. That paper that you guys published, was it the June 9th?
Yes.
Okay. So the question is, will there be an update to your June 9th UHERO brief?
Well, it seems like everybody's doing it, except they're just not writing it down. I mean, they're doing it for us. I mean, Tony's going to talk about it probably tomorrow. We talk about updating it, and then we get distracted by things that we think are really more important. And like right now, I was really distracted by the Pacific Islanders, and I really feel good about what happened is what's going on there. And we get, there's just some real things that we can sink our teeth in rather than get into a political broil. The logic and the methods and the resources. Now, the resources, you could make a case that there's a problem with resources and feasibility. Okay, I mean, the tests are changing. We're going to get, there's nothing like, so I've gone through all the testing you can possibly get. I first got Scott to do it, so I know what it tickles like, to get double nasopharyngeal specimen taken. And they put it right down to your tonsils, all right? It was a thrill, right? Okay, but I got to fill out the form. I got my pulse oximeter taken. I got the screening for symptoms done. I actually went through the whole thing myself, so I know what people are experiencing. Then I waited and waited and waited. Okay, so any test, if it had 100% of whatever you wanted, and you have to wait for it, I mean, come on. You don't need to be a brilliant figure that one out. So then I took another one, and they didn't use two swabs. They used only one, and then did it on double. Okay, and then I did a third one with his True North thing. I was right there on the campus with everybody standing around at the medical school, including the dean, sticking stuff up his nose. Okay, and True North got my results back a week later, right? So now I was really curious about the antibodies. So if I have IgG and IgM or both or one or the other, I got to get out of jail card. I've had COVID. Okay, if I have those antibodies, I'm good, right? So I took it twice in two different settings. In the second setting, I was thinking if an ordinary person has to go through this, because I know the lay of the land in the medical system here a little bit better than the ordinary person does, right? But if I had, it was ridiculous. I mean, it was just like you had to literally climb over people to get this done, and then to get your test back again. Well, that was not as crucial in time sense, but the whole implementation of testing and contact tracing has been upended by so many reasons. One is the time turnaround. The other one is the Department of Health. Okay, now there's a lot of good people in the Department of Health. I know I've been in that place for 20 years now, or 30 years. We had a really great programs there. But there was clearly problems, okay? And supposedly these problems have been addressed, and we have a new leader. And I think she's great, okay? She's certainly an outstanding emergency medicine physician, outstanding administrator of HMS. And then Jonathan tells me, he says, she is great. And she's an emergency medicine guy. And these guys are into prevention over here at the Department of Health. You say emergency over there, they're going to jump out the window. You know, and it's like, this is like, why did they get somebody from public, you know, it's like, ugh. But we figured that this is somebody that the governor is comfortable with. She's certainly a fabulous person. And I hope that she can make some changes. But we're starting off with institutional resources that we would have wished we had from a half a year ago. Okay, now there was a little story behind there that's really good. There's a thing called food safety. And way back in the summer, early summer, I had gone to, I was walking around in a restaurant, everybody's wearing masks. And I happened to glance in the kitchen, nobody was wearing a mask. I went, what the hell is this? And so I found out that the rules of the city were that the kids in the kitchen were exempted from masking. So I had this old friend that's head of food safety in DOA. She's a terrific guy, absolutely sterling. We couldn't have someone any better than him. He put up all these pass signs all over the place. You've seen them, the green pass signs. And I called him, he was saying, it's making me crazy. He said, D, I'm pulling my hair, I can't stand it. And I said, well, let's just do it, you know? I mean, and I didn't say that actually. I said, I know some guys that can influence some people around here. I'll talk to them. They went and talked to them. They said, yeah, you're good to go. Turns out they weren't. He just did it anyway. Okay, he just did it anyway. And so your salad is now COVID free. You didn't get a COVID salad dressing. Okay, thank you very much. And here's a guy that nobody knows, that everybody sees, and he did something really terrific. Okay, it's a good story. And there's not enough good stories around here. And so that is, and there are some, but we need, I mean, right now we're the ones that are going to have to buckle up again. Okay. And I know it's tiresome. But actually this technology is extremely, I mean, you don't have to put any batteries in the mask, you know, you don't have to reboot it. There is one kind of mask. Yeah, right. Rebooting your mask. And there is ways to handle it. You cannot wear your mask over your E. coli. It doesn't work. Okay. And so, and you need to keep the thing, when you take it off, you don't hang it from your nose. You hold it in a hand like this, and you would always lay it down outside first and inside up, right? And get them cleaned every day or throw them away. Okay. There's this technology. There was something else I wanted to tell you about masking. It just doesn't require a college education. Okay, it just requires our sense of community. All right, and so that tool alone, and many places around the world, has saved. So one of the things I did yesterday, I think it was, I went and tried to figure out what would have happened here at this point if we had done nothing. You know how many deaths we would have had?
Nope.
This is just a simple SEIR model. They're stupid. I don't like people to use them, and I don't like this hammer and dance silly stuff. But if you just do those crude numbers, okay, and they did nothing at this point, well, at this point we have less than 200 cases dead, right? It's going up toward 200. If we'd done nothing, it would have been over 11,000.
Wow.
So we're doing something good.
Yeah.
Shake your buddy's hand. Hey, Charlie, shake Mel's hand and pat him on the back. Come on. You guys are friends, aren't you?
Yeah, we are, man. We are.
All right.
You know, I think the lockdowns, the restrictions, the mask, all of the requirements that was put into play, the testing, you know, even though, you know, the numbers of testing has dropped dramatically. I was looking at the numbers today.
It's going down. It's going down.
way
It kind of
down.
bumped up around the in September, but right now what I'm looking at is actually flat or going down.
It's going down, and so is that an accurate depiction of what's really going on out there? But Doc, before and you talked about antibodies, just wanted to because there's some are saying the antibodies last only for a period of time.
Okay, so the antibodies I'm talking about were a test for antibodies that I would have had if I had recovered.
Right.
It's just a signal, nothing more, nothing less than I have had COVID-19.
Doesn't mean that you're protected or immune or anything like that. It just says that you were.
That's what it says. Now, I would say I'm good to go. That's me. That's me talking as a virologist of all the experience I've had with immunology and virology over the years. The experience I had with coronaviruses from years ago when we were working with it, my other buddies so there's rhinoviruses, adenoviruses, coronaviruses, influenza. All of these are respiratory illnesses. Influenza, you have to get a booster every year, Our immune system to respiratory infections are not as long lasting, but we have some really great people in tropical medicine that know immunology even better than I do. And there's a thing called anamnestic response. Okay, so antibodies are one type of response. They're antibodies. They're just protein molecules that will latch on to the invading pathogen, the virus, and inactivate it with complement, okay? There's another cellular response called anamnestic response. It's the T cell, B cell response. And for dengue, that memory lasts for 40 years. For smallpox, it lasts 60 years. There's no antibodies around, but that antibiotic response, memory, it's immune memory, will last for decades, okay? We all know this. And so while everybody's wringing their hands about it, I'm thinking, well, man, if I have antibodies, I'm just going to stop worrying about it, okay? Unfortunately, if I did have antibodies, I'd still go around with my mask on. I don't want to be caught anywhere right now outside with my mask off. Right. Bad. Okay. So, but the idea that people are worried about catching it again, I think there's one extremely rare case that was documented that the guy got it twice. But look, you're going to get run over as a pedestrian here first. Mm-hmm. Which is a problem here, by the way.
Yeah, it is in Oahu, that's for sure. Specificity and multiplicity.
Somebody asked you this. Oh,
yeah,
they're
somebody
back there.
posted it.
It's this chat line. I don't even see that they're posting these things up. Okay.
Yeah, there's a ton actually, and there's a lot. Again, a lot of them are policy that we're not going. We already said we're not going to be talking about political policy, and this not. We want to utilize you for the expertise in the virus. So I already made that clear. We're not going to be going down that road.
I'm happy to do the science.
Yeah, and so someone
probability.
Asked, is it possible to discuss specificity and multiplicity as it relates to testing in a way that we can understand? Okay.
Sure.
Fire away.
Sure. So, so the test that we have, let's say the test that stuck up in the nose, all right, actually is based on trapping a piece of the viral nucleic acid, the RNA. And then in reverse transcriptase, it will get it and then make DNA out of it, and then it'll give a positive signal. You got it, okay? If you have the virus and it misses it, that's sensitivity, okay? If you put the thing in there and it came out and it was positive, but you didn't have the virus, that's specificity. In other words, you can have people getting on the airline that are getting tested, and some of them might be positive, but they are false positive. That's that poor specificity. Most of these tests, the specificity is very high. It's up close to 100. But if you're testing thousands of people, there's some people that are not sick. They can't get on the plane. And they're not sick, actually. It's a false positive, not a false negative. Okay, and so these are terms that we used to describe our testing. One of the big issues with specificity was with the HIV. Think of getting a false positive for HIV. It's sort of upsetting.
Mhm.
Well, we have a backup test to make sure that it's not a false positive, or it is a false positive. It's a test called the Western blot that you do on every person that's ever tested positive for HIV. Okay. For the negatives, you just do another test. That's multiplicative probability. Okay. So if the probability for a for sensitivity, now the sensitivity here, the PCR is extremely sensitive. I mean, this stuff will be picking up virus from people that have recovered that the person's not infectious. It's just so small amount of virus around it. It's so sensitive, it's picking it up. All right. But if they did it wrong and they missed it, or even worse, you were in the latent period and you're infected, but you're not even shedding virus yet, it will be negative, and that will be a false negative, and that's sensitivity. And that's what most of the people obsess about. But if you do two of them, say one on one day and one on the next day, you get the benefit of sampling twice, and it's multiplicative. It goes from something like 0.53, let's say really poor sensitivity, from 0.53. On the second test, it goes to 0.77. You're getting 77. The third time, you're almost home free. And these quick tests, these quick saliva tests that are coming out, they're going to cost $4 or $5. Scott and I were going to ambush them. We had a plan. We had a plan. Yeah, we had a plan. Boys got together and had a plan. Okay, we were going to get Taiwan, because FDA won't sell them to you, jerks. And so Taiwan is going to buy them. Okay, they're going to buy them, and they're going to route them through Honolulu. Don't tell anybody about this now. Nobody's listening, right? Okay, so
no, nobody's listening. Nobody's
right.
listening.
So we're gonna route it through Honolulu and pay the Taiwanese off and hijack the container full of these tests and just use them. Just give them to people. You have to hook it up to an app. And right now, people can't even get their safe app that's getting this lab up over at school to work. But they got to have an app, and you can be testing yourself every day. We don't even need contact tracing anymore. You just blanket the community with these tests. This is Dr. Michael Mina from Harvard. He's a really cool young guy that figured out this that you could do this, and it would be really effective. Because if you're getting a really, really sensitive test, but you don't get it for 7 days, ouch. This is like you get it in 10 minutes and your app reads so this is like a pregnancy test. I know those guys know all about pregnancy tests, right? You know how to do that. It's really simple. It's a little cassette thing, okay? And you put some drops of stuff, in this case your saliva, on it, and it changes color. Now you better know red from blue, all right? And that's the problem. So you get the app to actually read it for you. And it's got a QR code on it. The whole thing goes to you and to the boss up, over at DOH, wherever you want to take it. And that's going to revolutionize controlling it from the epidemic point of view. Now, so I don't know if that has answered their question about multiplicative probability or Bayesian probability, which is a little different. This is the Reverend Thomas Bayes back in the 1700s that dreamed this up. And that's why I like pre-testing. That's why the blood bank likes pre-screening, not testing, but pre-screening. You're getting picky. You're making sure that this group of people already is very likely negative. It's a prior probability. And Thomas Bayes, in all his genius, while he's standing up on the podium preaching to everybody, the Reverend Thomas Bayes, published this. And he said, your test machines in the future, these test machines that you're going to dream up, they're going to work a lot better if you pre-screen the people. So in the airline and travel, I always wanted and we didn't even get around this. I had a big talk with my buddies, Sumner and Tim, about pre-screening. Okay. And so they said, well, they won't do it. People won't participate. They'll lie. Then they'll go out and party. I said, you got to do it. You've got to do this pre-screening. Most of them won't, because they're going to invest in this. They want to have a good holiday, right? And so that really makes the test perform better. And you can't really I can put a number on it under certain circumstances, but it'd be too complicated. I'd have to kill you after I taught you to do that.
So on your pre-screening, is one good enough?
Well,
Pre-screening?
it's a series of questions about what you've been doing, and and it includes a pulse oximetry, it includes a temperature check, it includes a symptoms check, includes what you've been doing. It includes saying you haven't, to your knowledge, been in contact for the last 14 days with anyone that was suspected of having the virus, and what you're going to do between now and when you get on the plane. Okay. And so, and I don't even have it in front of me. I make these lists up and I give them to Summer and Tim, and they throw them away. And I think, oh, where is that list again? And so, but they know they've been to church. They've listened to the Reverend. They got the message, and so they know that that's a powerful tool of a priori probability. It's a mouthful. Sign up for my PhD in epidemiology, and I'll have you multilingual in no time.
I think me and Charlie are going to sign up.
This is one of the great things in my career also was teaching and having great graduate students, PhDs and Masters of Science here and in Michigan and in other places in the world. I've been on committees in other places in the world. It's been just terrific.
So aside from your pre-screening, pre-testing, is one okay?
You can only do one. I mean, the person comes in and says, "What have you done last week?" Why would you ask them again? Because
what I mean is do a
oh, okay, testing. You're talking about testing.
Right.
Okay, so it depends on the test you use and when you use it and how soon you get it back and how soon you do it before you get on the airplane. Okay, all of these things are beyond my jurisdiction. Mm-hmm. I can tell you what you should do scientifically, and we talked about this so many times. Like, are you stopped dreaming now? Have you stopped, smoking that stuff or something? Because you're out of touch with reality. And so, I mean, we know how stubborn our institutions are, and how absolutely pathetically slow the highest office of our government here moves. I think it's just incredible. I am so utterly out of my wits over what the governor has done to this state previously with TMT and the Hawaiians. He had great opportunities to solve two problems at once and just blew it. Okay. And now he's just, I mean, we just don't talk about it. That's the best thing to do, because we can't do anything about it. I'm not on any of those teams. I'm not on any of these things that are in the decision. I didn't make up this color-coded tier thing. It makes me dizzy to look at it. Okay, I mean it really. I just know I got to put my mask on and behave and hope for the best. Okay, I can't do the crowds that I like to. And but fortunately, I can talk to my colleagues all over the world, which I do, which is great.
I think as it relates to the multiplicity, though, because the characteristics of this virus, because there is that period of time, as you described, that
it's called latency.
I think latency.
Okay, so let me. There's a good point, Mel. It's a really good point to bring up, because it reminds me to talk about the natural history and the life cycle of the virus. Go ahead, but I want you to finish your question.
The question is really, if you take that test 72 hours, let's just say, and we're talking about the science of it, not the politics of it, but the 72 hours, and they fill out their forms. Hopefully they all tell the truth. You know, I mean, that's asking for a lot. Asking someone to put on a mask is asking a lot nowadays, but so they fill out the form, they take the test, they come here. There is that period of latency that is, I think, what concerns a lot of people is because
most people don't even know about latency. They're talking about a 72 period of time where if their test was negative, they go and get infected.
Right. Those that are infected but not shedding their virus, their test came out negative, but they actually have been infected but not yet shedding. That I think is a concern.
Okay, so can I start with time zero? Okay,
Mhm.
so time zero is a person that gets exposed to the virus.
Okay.
Okay, so they have to either stick it in their eye, up their nose, in their mouth. And at that first stage, there is an issue of dose. Okay, more virus is the infection produced by a person exposed to more virus rather than a person exposed to less virus is going to be different and have a different course. Okay, the person that's exposed to more virus is going to have a shorter latency and incubation period than the person with less virus. So right there is the first step of thinking about. Okay, so now the person's exposed. What happens? Let's take tissue culture. Tissue culture is how you grow the virus. Okay, it's a flask that has living cells in it. They're called vero cells. They're from green monkey kidneys. Okay, and the virus loves to grow in these cells. Right. The whole technology is in these little plastic box kind of things that have a thing on it. It has media in it, and the cells are growing. You've built up this tissue culture, and now you're going to introduce the virus into it and grow the virus. Okay, and you will introduce a certain amount. We will measure it. We'll put it in there. Okay, and so you come back and you pet it and you blow on it, you whistle and you sing and dance around it, and and really, I mean, the tissue culture is just not, they're maddening to work with. But there's some people in the Department of Health really good at this, and so you keep looking through the microscope at it. You come back next morning, is something going on down there, guys? And so when the virus actually gets inside the cell, it starts wrecking the machinery and using it for itself. And so over a period of hours, that cell starts taking on a CP, cytopathic effect. It doesn't look like a normal cell anymore. It's starting to look odd. Okay. That doesn't happen for several hours, sometimes like maybe 24 hours. And that's in tissue culture. Okay. If you get infected yourself, that virus has to get into the cells in your nose, in your mouth, and into your respiratory system and into your lungs, and then penetrate the cells and start setting up a growth cycle, making new viruses. And they got to make new viruses to destroy the cell and emerge. Okay, so anybody gets COVID is going to have some tissue damage at the end of the day. Hopefully, you're not too old to regenerate some of that stuff. Okay, so that then releases the virus. So that's an incubation period for the virus from the time it enters to the time it emerges is incubation period. The person now may be shedding virus and have no symptoms whatsoever. It's called asymptomatic transmission. Okay, that's dangerous because you there, but you can test them. They'll test positive for PCR. But those hours between when the virus latched on and started building up some new virus before they tore the cell open is a latency period. Generally, in viral infections, this is really a rather short period. Okay, but we don't really, kind of hard to do this. You can't experiment on people, remember? So how do you know when exactly? Yeah, right. Don't do that. Okay, it's the Helsinki Accord. It's really bad. Okay, Dr. Mendel, you're not that. Okay, so when they actually get exposed, well, actually, I have to tell you the truth. Back in the 1970s, the British used to infect people with coronaviruses and put them in a trailer. Okay, well, they were coronavirus. This is a wuss of a virus. All right, until SARS came along, it didn't do anything. They just used up Kleenex. Okay, and so, but they could actually do those kinds of transmission experiments. But this is way in the 1970s when people were different. Okay, and so, as you know, because you were there, and so, so this little period of latency is a problem, as well as the viral shedding when you are asymptomatic. Okay, and this is a problem because you can't see it, but they were wearing a mask. Don't forget they're wearing a mask. So if they're wearing a mask, even though they're getting sicker and they're starting to spreading virus, it's not going anywhere. The survival time of the virus outside the body, I said it was wet and messy. As soon as it dries out, it's desiccation, it's dead. The survival time is exponentially down. It dies exponentially outside the human host. Pretty quick. It's nice. You want to get rid of it. So nothing about this epidemic, by the way, is linear. a little bit of transmission can actually go a long way. We can disrupt inter-household transmission. Proven. Okay. Just get everybody in the house to mask up. Okay. Wash their hands. Be really careful with everybody in the house. You can actually do that. They've proven it. They've done it in China and elsewhere. All right. A little bit of virus, as you know, can go a long way. In the right setting, you have these crowded events. You have somebody that's singing their heart out, and they just infect a whole lot of people. I think we just had one somewhere around the in Washington. Yeah, stop it, Charlie. Stop it right now, Charlie. You're on me.
There's been a few. I actually have a specific question as it relates to Washington, and it. I hope you can answer this, but it says, question for the doc. President got monoclonal antibodies. They have been used in cancer therapy. They lose effect and need to be re-administered. Is that the same case with their use as an antiviral? If so, how long between treatments?
Well, these are two different things. An antiviral is a pharmaceutical. Okay, it's not an antibody. An antibody is a particular type of protein structure. It kind of looks, if you look at the letter Y, but it's at the level of a molecule, okay, is what an antibody would look like. It's got two short parts and a long part, okay? I'm supposed to remember all this antibody anatomy right now. So you can actually manufacture artificial monoclonal antibodies rather than what historically people would get diphtheria, they would get tetanus, and we would immunize a horse with diphtheria and a tetanus, and then take the horse serum and give it to the person. And it's called passive immunization. You only do it once because the person's going to make antibodies to the horse antibodies. The next time you do it, they're going to die from anaphylactic shock, like a bee sting. Okay. But now, because of the wonders that we can do in the laboratory of making artificial monoclonal antibodies that look like, for all intents and purposes, human antibodies, you have to inject it as if it is a treatment, but it's not really a pharmaceutical. And it acts as an artificial immune system. It's an incomplete one because it's only antibody. It's an antibody response. It's not an antibody and a cellular response, which is more effective. Okay. And it's been shown to be effective with Ebola. And I mean, we've already known that passive immunity works. I mean, it's just tons of research that go back decades on this. It's just that we have the ability to make a much cleaner, and how long they use this, the physicians, they give the injection on Tuesday and give another one on Thursday afternoon. I really don't know what the half-life is of the antibody, how effective it is. They don't know how effective the monoclonal antibodies for COVID is because they've done no clinical trials. They're just doing this on the history of experience that we have with it. Pharmaceuticals, some new remdesivir is a pharmaceutical. You just give it as a drug, okay? And it's supposed to, so a really good direct-acting antiviral like the ones for hepatitis C actually go into the cell, attack the virus at the nucleic acid level at replication. These are how the highly active antiretroviral therapy for HIV work as well. They're very effective. They target specific viral replication. And it's all made, this didn't come out of the forest and the trees. These are really smart guys working in the laboratory. They make this stuff up from scratch. They really know how to do it. It's really fabulous, fabulous science, okay? So this is, even more powerful ones have just recently come on the market. I don't know where they are right now. You spray it into the nose. It's 2,000 times more efficacious than anything else they've used. So it's going to go through clinical trials pretty quick. This is therapy, okay? I don't want therapy really. I like it because it's going to save lives right now, okay? But it's better if we could just prevent it. I mean, we've already saved 11,000 lives. Remember?
Yes, that's a good number. That's a good number. I know, Doc, we way past our time, and I mean, I don't want to let you go, but I respect your time.
No, I'm good. I'm good. You just want to get out of here. I know you want to get out of here, man. I can tell it. He's had it. Will's had it, right, Charlie?
I'm actually thinking about becoming an epidemiologist starting tomorrow. I'm gonna.
No. Bad idea. It's,
I,
listen,
I,
listen, Mel, this is one of the things that attracted to me. It's really, epidemiology is completely separate from medicine in the way it does things. It's extremely creative. It's been a terrific career I've had, but it's not what people think it is. All these people that have swarmed around me that are amateur epidemiologists are just, to me, they're just loose guns. They're just dangerous. Okay, and it worries me. They're good intention. Good intentions is a road paved with, to hell.
yeah, no, I understand. I mean, it's tough, but it's very interesting.
Just go and get help Angela. Go get other people to mask up, and you'll be doing a lot right there.
I just had one more question. The test you talked about, because I had the test, the PCR that went all the way in the back. But now it seems like they're having people self-administer the test and not having to go all the way in. Is that nostril area, is that a good source to check or for the virus, or with the PCR that goes all the way down, based on your experience?
Well, when they tested these tests side by side, they pretty much tested the same. Okay, side by side. They would get quite a large number of people that they already knew were infected, and they would do it side by side. The one that's even better is just saliva. I mean, I got tons of saliva. I dribble all the time. I don't even need to even try. I mean, just like, okay.
So with the saliva test, with all of these new tests coming on the market, that it's very simple. When you get institutions like the jails or schools, universities, again, even going back to the travel, wouldn't it make sense to test more often?
You're absolutely 100% grade A plus right. You passed. You're absolutely correct. I couldn't agree with you more. With these quick tests that are cheap, we would do them. Okay, once a day's enough. Okay, you don't have to get obsessive about this.
But really,
we would be getting as many as we could to get to as many people. But what you said is very, very important, is to target the places where the kids are piling onto the university campuses around here. Chaminade, HPU, up in Brigham Young, and they're partying.
Yeah. Well, even what we're seeing in professional sports right now, football, basketball, you'll see, and they're in the bubble. They're supposedly following these strict rules. Humans will be humans.
I play tennis, single tennis. I only play with one other guy tennis. That's all I do. I don't like any other sport except free diving. And I told Daryl Huff that you had to socially distance underwater, like everywhere else.
Damn right. No discrimination here.
Yeah, scuba diving, free diving, you gotta have social distancing underwater as well. He was asking me about surfers. He wanted to know if I should recommend that surfers should have physical social distancing. And I said, of course, because you have to have one. You can't confuse people with all these different messages. I said, yeah, they have to have social physical distancing. All right, just like everybody. And if they're underwater, they have to do it too, damn it.
Charlie and I, we've been doing this now almost 7 months. And I think sometimes we forget, but I got to say, probably 90%, not even more than 90% of our discussions focus around, well, they all focus around COVID, but we trying to pound into our viewers' heads about the importance of wearing a mask. How simple is it to wear a mask? And if you don't care about yourself, care about the other. Wear your mask, wash your hands, social distance, avoid gatherings. Very
pass
simple
it
things
on.
to do.
Pass it on. Pass it on.
Well, we try, but
I know you're doing it. I know you're doing it. You're doing it better than I am. I don't know how to do this damn Zoom stuff. And so you're doing it much, much better. And it's why I'm here talking to you, man. I really salute what you guys are doing. Yes, sir, I really do. I think it's fabulous. And I really, really I hope that you will keep it up and knock their socks off. I think you're doing a great job.
I appreciate you said something earlier tonight about the damage once it gets into the respiratory, inside. Right before my brother died, because he succumbed to the virus in New
I'm
York.
sorry to hear that.
He,
I
he
really
was
not
he was
really,
one of the first 3,000 in New York that fell. But
I'm
when I got to take
sorry, Charlie.
thank you. When I got to take a look at that report, they said that his lungs were just busted up. In fact, he was one of the first that they couldn't understand. I had made mention to the other doctors we brought on when the virus hit about the thickening of the blood. They tried to dialyze him and it just wouldn't work. It just kept on clogging up that dialysis machine. And next thing
Oh
you know,
God, that's terrible.
you hear about all these things. So, I think for our viewers and many of them are so appreciative you came on tonight, Doc, and getting from a medical standpoint, because before we got a lot of good guests, There's no doubt about it. But going into the scientific side of it is very, very fascinating. And just listening to how you explained it, you made it very, 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 very well put. That I enjoyed it. I thought I'll get like, oh, I'm gonna get overwhelmed, but it's darn right on the nose. Because when you said about the destruction, I could relate to that. I said, okay, now I know what you're talking about. Because that's what
Well,
happened.
that's viral pathology. It's COVID. They have bilateral pneumonia. That's how they present. You can see it on the X-ray. It's classy. It's called ground glass pneumonia. And
Mhm.
you say, oh, this guy's got, and his lungs are filling up with fluid.
Yeah.
Um, but again, I think that you guys can help us prevent it.
Yep. We'll
And
try.
that's what we have to do right now, and getting our community to put things aside and work together to do this is really important at every opportunity. And that's why I was happy to be invited, and I really appreciate very much your invitation.
Well, Doc, we have a bunch of comments from people saying this is the best show ever. There's a bunch of comments asking for you to come back on, and we definitely will want to have you
Thank
back
you.
on.
Big aloha, mahalo.
But Charlie, before we go, Charlie, any closing comments for the Doc?
Well, as always, I always like to give my greatest aloha and mahalo to you, Doctor, for coming on tonight. It's much appreciated. Thank you very much for sharing your expertise. And to our viewers out there, it's always our objective is to educate and inform. And we hope you walk away with something useful. And if not, there's always another night we'll be on and we'll bring on some more information for you to learn. But the thing that we can do right now, because we don't have a vaccine, we don't have a treatment, but we do have masks, we can wash our hands, we can distance ourselves. Just do that for now, and we'll be ahead of the ball game. So thank you
Pass
very
it
much.
on. Pass it
Mel,
on.
up to you, Mel.
Doc, thank you so much, man.
My
You
pleasure.
presented it in a way that we could understand most of it anyway. Some of that stuff went so quick over my head, but by the time you summarized, I understood it. So I appreciate, man. Appreciate, especially for us Portuguese people that
Oh, really?
we struggle. We
I'm
struggle.
an East Tennessee hick. I just grew up down the road from Dolly Parton. Okay, and she told us we're not Southerners, we're hicks. Okay.
So you say you grew up in Sevierville?
Yeah, Sevierville, the sheriff down at Sevierville, the credentials for elections of the sheriff in Sevierville was pre-incarceration.
I lived in Pigeon Forge.
Oh, really? Oh man, I just listen. That's just this is like where the family farm is still there. The houses and homes are still there. You know, my roots are there, man. I can't tell you. I mean, I missed going to see them this year, and you should hear them talk. You know what it sounds like, Charlie.
Yep.
They are so funny when they talk. He says, they heard that why it's so sweet it give you diabetes.
But when I first went there, they said, "Hey, you don't want to go to a country fire?" I go, "What?
Huh?
You want to go to country fire?" I go, "What fire?" "The country fire." I go, "What are you talking about?" "The Ferris wheels." I said, "Oh, okay. Now I know what you think."
My wife is Canadian.
Oh boy.
So pardon, she's saying pardon. They're saying what? You know, I mean, it's just like, ah.
So I didn't realize, Charlie, you're a hick.
Yes, I am.
No, I
All right.
spent a lot of my life growing up on the farm. I split it with also growing up in the city, in Knoxville, in both those places. But I'm very connected to those homes and the people there. And really, I'm not a good student. I was never a good student. I told them that what Mark Twain said was true. I get my education. I said, what is it Mark Twain said? Don't let school get in the way of your education. That's me. That's why I really just did this, because I wanted to do it, and I'm stubborn.
Well,
And I was really lucky. I had a really great career.
you have helped a lot of people, Doc. You've clarified as much. I hope you go back to my Facebook page and you can read all the comments. It's just positive all the way.
Am I supposed to answer some of these things, or what?
You can choose to. Yeah, there's some questions on there that you may want to answer.
Okay,
just go
I
right
don't
to
know
my
how to
page
do
and-
that. You just tell me on the email, and I'll do it.
You'll see after every comment, you'll see a little thing you can click on reply, and you can respond to them. But there's.
Well, I
gonna be
saw
a
the
lot.
ones from yesterday streaming up on the side of my screen, but I don't see them today for some reason.
Yeah, because we're on
And
Zoom.
I didn't want to
on Zoom.
answer most of those yesterday, to tell you the truth. Yeah.
But
Jeez.
anyway, I actually went to McGee Tyson Air Force Base.
Really?
That's right.
Did you see that sign over the highway that says "Buckle up, y'all! It's the law"?
Yes, I did. You know what? I actually, when I came
You're
back
saved.
from Tennessee, I said the only other place that I saw the Aloha Spirit outside of Hawaii was in Knoxville, Tennessee.
That's it.
It really was, man. But
You
anyway,
didn't go up country past Sevierville and on the way to Scoresville.
no, man, I
or
was
they
pretty
will.
much-
They'll knock your socks off.
You go up to
See, I'll tell you
Gatlinburg,
something else.
just go up to
The
Gatlinburg.
Egyptian people are some of the most hospitable people I've ever met in my life. They really are a remarkable group of people. I've been so lucky to work in that country all over.
Well, let me know the next time you go. Charlie and I will go and carry your luggage and
No.
make sure
I
you-
already got that covered.
Anyway, hey, as we wrap up, people, listen. The best thing you can do tonight is to share this video. Share this Facebook post tonight. You can share it at any time. Share it and ask your people to share it, because it's important that the people get the right information. Really,
Thank you.
from world-renowned doctor, epidemiologist, incredible
Right.
opportunity for all of us to listen, and appreciate you, Doc, so much. So everybody hit the share button. If you're watching this on the replay tomorrow, you can still share it, and it'll replay as if it was live. So thank you again, Doc. Viewers, thank you so much.
Thank you, Mel. Thank you,
Appreciate
Charlie.
you guys.
Thank you, Doc.
We love you guys. God bless. We'll see you guys tomorrow night, 7 o'clock. We'll do it one more time.
Aloha.
Stay safe, everyone. Aloha.